Hello and welcome back. This is lesson 3, low back pain management. Back pain is a huge problem. We're just going to be skimming the surface. Let's get a little bit of background. Let's talk about the prevalence of back pain. Back pain prevalence is very, very large. Most of the population will experience back pain at least once in their life. At any given time, 20% of population will be experiencing back pain. Females tend to be at higher risk for back pain, and the older you get, the more likely you'll be experiencing back pain. There are many different types of back pain. The one that we're going to be focusing on today is back pain that's referred to as mechanical back pain or primary back pain. We've already discussed back pain that causes radiculopathy or causes spinal stenosis. And then finally, there's back pain that's caused by a more specific and oftentimes a pathological process like a cancer or infection. And we are going to talk briefly about inflammatory back pain, but just very briefly. So these are the causes that are most commonly involved in back pain, with the primary back pain being by far the most prevalent. The good news is the back pain, for the most part, responds quite favorably, and most people get back to doing their normal activities and back to work within 4 to 6 weeks. There is a small percentage of people who don't go back to work and have still difficulty doing activities at 12 months, mostly around 8 to 5% of the population of back pain sufferers will end up having chronic low back pain. Back pain is a chronic recurrent problem. Once you had your first episode, that's a strong predictor of future episodes. And you'll get recovery from a back pain episode, then you'll get another episode that impacts your ability to work. When that resolves, then you have another episode. This time you have pain even when you're at work, and it may impact your ability to function. So back pain is a chronic recurrent problem, many flare-ups and many episodes along the way. Back pain is the most common cause of disability in the world, number one. It's also the most expensive healthcare condition. It's more expensive than cancer, more expensive than cardiovascular disease or diabetes combined. And these disability rates and costs for back pain are continually rising. So why is back pain such a big problem? In terms of prevalence of back pain seems to be consistent no matter where you go around the world. Third world countries or first world countries, urban, rural, it doesn't really matter. Back pain prevalence tends to be the same no matter where you go. And why is that? Back pain seems to be part of the human condition, and likely due to this evolutionary process from quadruped to biped. And biomechanically, we're not just there yet, and therefore back pain tends to be as a result of this lack of fully evolving to the biped posture. So trying to prevent back pain is probably not where we should be putting our money, because that's probably futile. What's really important is trying to prevent disability, because disability varies considerably in various jurisdictions. For example, in California, high risk of disability for back pain. Why? Because their healthcare system and their insurance system, it promotes disability. It provides incentives for people not to go back to work, but to be off work, unfortunately. And this causes a high risk of disability from back pain in California. In Japan, on the other hand, because of cultural reasons, that people continue to work despite having back pain. And again, this is a cultural thing. So here we have different rates of disability in different jurisdictions, not to do with the back pain itself, but to do with other factors, and other factors including issues around healthcare, insurance systems, workplace systems. All these other factors can impact disability from back pain beyond the personal issues around the back pain for that individual. Another factor is the aging population. As we mentioned, the older you get, the more likely you're going to experience back pain. And because we have an aging population, that makes patients more at risk. Another thing is sedentary lifestyle and lack of physical activity. This is a huge problem in the Western world, and as a result, increased risks of back pain. But this is the big one, mismanagement of back pain with or unnecessary imaging, unnecessary medications, unnecessary advanced testing, injections and surgery for primary back pain, which really, really drives the cost up. And there's attitudes and beliefs that are perpetuating disability for back pain, and that's what's really, really driving high disability rates. So how can we do a better job in reducing disability for back pain? Well, the first thing is we need to provide reassurance to patients, and we do this by ruling out red flags. And then once we've ruled out red flags, patients have primary back pain. And primary back pain, as we talked about, is a condition that gets better. Okay? But the thing that minimizes them from getting better is the psychosocial factors. So we need to do a good screening for patients, because psychosocial factors in patients are one of the strongest predictors of failed recovery from back pain. But the good news is that if we identify them early enough, we can intervene and change these psychosocial factors and their impact on recovery. So how do we manage these patients? Well, let's start talking first about the acute episode of back pain, because where's our opportunity to prevent that flare-up in back pain or that first episode of back pain becoming chronic. So this is by the positive messaging that you will get better, that you don't have a serious disease, and keep patients active and get them back to work and get them back to do the activities that they need to do for their daily lives. These things in terms of interventions like acupuncture, manipulation, massage, heat, that's only to promote activity, to get them going, not as a sole standalone treatments. But getting back to activity is really the key, and changing attitudes and beliefs earlier on that this problem will resolve. It's not going to make you crippled. You're not going to be disabled for the rest of your life. This is really, really important positive messaging. Unfortunately, if you do end up getting people with chronic low back pain, then you need to have a multimodal approach, because there's a multitude of factors that are impacting the chronicity of their back pain, both from the physical perspective, the functional perspective, and most important, the psychosocial factors. Because in most cases, the initial injury has resolved, but the patient continues to be disabled. And that's where you need to change attitudes, change beliefs, provide strategies around how they can manage their pain and get back to doing activities. So here are some myths that are really perpetuating disability and back pain. And if we can avoid these myths and we can really do a better job in promoting activity and minimizing disability from back pain. First myth, let the pain guide you. Once you've ruled out red flags and you have primary back pain, you should be promoting patients to work through the pain. The pain will not harm them. The next myth, an MRI will find my pain. When you have primary back pain, MRIs are useless, and they're not going to be helping you manage your patient's pain. Only when their patient's not getting better or you suspect serious disease, when you're suspecting that maybe something else going on, then perhaps an MRI might be useful. But at primary assessment of back pain, MRIs are not going to be helpful. In fact, doing unnecessary MRIs will actually perpetuate disability and worsen your outcomes. Myth number 3, medication is all I need. Medications are not first-line treatment for acute, subacute, or chronic low back pain, or even radicular back pain. Medications are not the way to go, but more activity, education, exercise is where you need to go with these patients. Pain intensity, we also get fooled that pain intensity is a marker for the amount of damages that's in the low back. This is not true at all. The intensity, we also often see back pain patients coming in with 10 out of 10 pain. That does not translate to 10 out of 10 damage in their spines. Number 5, rest is all I need. We know that resting for back pain actually promotes disability. We need to get patients activated. Myth number 3, back braces help patients with back pain. No, they do not. Don't recommend back braces. They actually perpetuate disability, cause immobility, and that's not what you want to do. Number 7, injections will help back pain. There are evidence-based guidelines do not recommend injections. There's no evidence that they're of any benefit. They're costly and they're not of any benefit. Number 8, spinal traction. Any form of traction does not help back pain, whether it's radicular or back dominant pain. Number 9, surgery will help my back pain. When you have back dominant pain, surgery is rarely going to be effective for patients. Usually, surgery is most effective with leg dominant symptoms. Number 10, and finally, back pain is a physical problem. No, back pain is a biopsychosocial problem. You need to deal with the physical, yes, but also the functional and the psychosocial, because it's the psychosocial that often drives chronicity. Let's talk briefly about inflammatory back pain. About 3% of back pain is inflammatory: ankylosing spondylitis, psoriatic arthritis, Reiter syndrome. The good news is that because of the advent of biologics, we rarely see deformity anymore in patients with ankylosing spondylitis. In terms of what we find with ankylosing spondylitis, in terms of the evidence, that the best results is when you combine pharmacological treatment and TNF inhibitors and NSAIDs with a non-pharmacological approach: physical exercise, manual therapy, and self-management strategies. There's no cure for ankylosing spondylitis. Patients need to learn how to manage the condition for the rest of their lives. And we're going to be demonstrating some of the techniques that we use for inflammatory back pain in the in-person session. So in summary, back pain is an extremely highly prevalent and recurrent problem. It's extremely costly and a high risk for disability. In fact, the number one cause of disability. We should not be spending our time trying to prevent back pain, because that's futile. What we need to be focusing on is preventing disability, and that refers to secondary prevention. When my patient has an acute back pain episode, that's the opportunity to prevent that acute episode from becoming chronic by positive messaging, activating your patients, not passive therapies, minimize investigations, and get these patients moving. If you do have chronic back pain patients, this is where you need a multimodal approach, dealing with the physical, functional, and especially the psychosocial factors, which are the main barriers to recovery. So, some questions for discussion when we get together in the in-person session. Do you recommend surgery for primary back pain? If so, when would you recommend surgery? These are some questions that we'd like to pose to you, and hopefully we'll have some rich discussion in our in-person session. And that concludes Lesson 3, Low Back Pain Management.